All right. So we're in here. All right. This is Trump and the GE. We're discussing the drug overdose deaths and also the recent mass shooting in Tulsa. I have with me Dr. J. Joshi, and Trump and the GE. We obviously discuss the economy and issues important to the community. I'd like Dr. J. Joshi just give a brief overview of his background. We've had him on the show before, but just reintroduce yourself if you would.
Thanks for having me, guys. My name is Dr. Jay Joshi. I'm a general practitioner in Northwest Indiana. I take an active role in medical and legal discourse as it relates to pertinent healthcare issues, particularly the opioid epidemic. You can find a lot of my writing on Daily Remedy. That's daily-remedy.com. Uh, my focus really as a physician is to advocate for patient-centric healthcare laws and healthcare policies, and often that entails understanding how lawmakers look at healthcare and how patients look at healthcare and reconcile the differences between the two. So thank you for having
Yeah.
me.
The drug overdose deaths and the so-called opiate crisis is near and dear to my heart because I've been an investor in companies like Endo International. I followed Mallinckrodt pretty closely before it went belly up, and also Teva, which sold opiates. And it first came to my attention. Well, not just over drug overdose deaths or opiates. It was really the drug pricing came to my attention. This is around 2017 when Bernie Sanders sort of threw down a gauntlet. He said that Gilead was charging like over $9,000 for treatment for his HVC drug, which was really a miracle in my opinion. It was started as his name is Savaldi. Started out as Savaldi. It was a miracle in my opinion. He said that veterans should get access to these drugs on par with everybody else. They should have the best treatment. They should be able to get it cheaply. And then the government started, sort of trying to tamp down the price for Sovaldi, and they introduced Vakira Pack, which came from AbbVie, to try to tamp down the pricing for Sovaldi. I think that triggered, Hillary Clinton and also Donald Trump, who won the campaign trail at the time, running for president, to look at drug pricing. Then you saw, Valiant, companies like Valiant that were basically just overpricing for drugs and increasing drug pricing. You see the guy Martin Shkreli, Pharma Bro. So I think it triggered, touched off drug pricing in general. And then Donald Trump went even further and said, after he became president, we need to do something about the opiate crisis. And because drug overdose deaths were going through the roof, and nobody could figure out why. They had surpassed, car accidents in terms of accidental deaths. And he said we need to do something about it, and we need to bring these drug manufacturers to justice. And so he said that we're gonna reduce the prescriptions. That's maybe one way of looking at it. You reduce the prescriptions, you may be able to reduce the deaths because the deaths were rising with prescriptions. Prescriptions were going through the roof, and so he did that. And over time, I looked up and I'm looking like, okay, so the prescriptions are declining, which is hurting sales for Teva and Endo International. Their sales, opiate sales, were falling really rapidly. They were dependent in some parts on these opiate sales, and but the drug overdose deaths kept going up. And I'm like, okay, so what do we do now? We tried cutting prescriptions. Now what? And so then I think Trump, when he said we're going to bring opiate manufacturers to justice, now you got state AGs across the aisle, Republicans and Democrats, saying we're going to sue the opiate manufacturers. That was the next step. And that was probably, in my opinion, probably one of the few things, if the only thing Trump did when he was in office that got bipartisan support. That now you have these state AGs that are getting the courage to go after opiate manufacturers and find a way to, I guess, bring them to justice. And there was a judge out in Cleveland, Ohio, who came with a novel settlement mechanism and say, look, this is untenable. You can't have you know tens of thousands of lawsuits. The opiate manufacturers can't go to court 10,000 times; they can't afford it. And he said, legally, you're not going to get a public nuisance claim against the opiate manufacturers. So let's settle this. Let's find a way to settle it. And so over time, I guess they began settling these claims. It's pretty much been a global settlement for the big distributors. I think Teva and Endo still has some overhang. They've been settling these cases one off, but there's still some overhang. There's still some trials. The trial in in Chicago. It's trials in Arkansas. I know there's a trial in Tennessee coming up next year for endo. I think Nevada is going to court, and I think Oregon is going to court. But pretty much it's been a global settlement. I think it's really the efforts of Judge Polster and this a novel settlement mechanism that create a pathway for settlements. So you have Johnson & Johnson that settled, and then the big distributors who settled. So it's also, you got some feedback from the judges that you can't get a public nuisance claim against these opium manufacturers, which is what Judge Polster said initially. So here we are. So now, what do we do now? That's the question. We cut the prescriptions, but drug overdose deaths still going through the roof. So in 2021, total drug overdose deaths were around 108,000, up 15%. This is the data from the CDC, recent data. The overdose deaths involving opiates were 81,000, up 15% year over year. Synthetic opiates, fentanyl, was up 71,000. Was 71,000, up 23% year over year. So, looked another way, of the overdose deaths involving opiates, synthetic opiates were about 88% of the total in 2021, about 83% in 2020. Other thing I noticed was that drug overdose deaths involving opiates were on pace with total drug overdose deaths. So it looks like it's kind of on par now, where it's really an outlier. We know that fentanyl is an outlier, but I think it speaks to a lot of things that what we found out, what people have been saying, what the pain patients have been saying, and what people in the know have been saying, that people I've spoken to said that this is not an opiate crisis, it's a heroin crisis. And you have people who habitual drug users who were taking opiates, who were getting addicted to opiates. They were driving the sort of opiate crisis, opiate epidemic, or the opiate demand. And when you cut the opiates, they just turn to, heroin or opiates on the black market. So these are habitual drug users, not necessarily pain patients. So this narrative that doctors were prescribing opiates, and the pain patients became addicted to opiates, and they're ODing. That narrative is being shattered now. People I've spoken to are saying this is a heroin crisis, and you have a bunch of wealthy individuals and upper middle class individuals who have access to. They can pick up the phone and call their congressman or their congresswoman and say, "Look, we need to do something about this." They may be slightly embarrassed that, maybe more palatable to say my son or daughter died of opioid overdose than to say my son or daughter was a heroin addict. And that narrative, and that seems to be what's playing out, right now. And you see the state AGs are getting off this narrative that doctors are overprescribing opiates, and that's called an opiate epidemic, because now the prescriptions are falling, but the drug overdose deaths are still going through the roof. So that's sort of the backdrop, and I'll just let Dr. Joshi speak to. What do you think about these numbers? It's consistent with what we've seen in 2020. What do you think about these numbers?
I think you hit it on when you talked about the economic correlates and looking at the supply and demand, because that's essentially how most lawmakers and policymakers look at the opioid epidemic or the overdose crisis, whatever terminology you want to give it. The terminology really is seen from an economic standpoint. So people will always look in terms of supply and demand, and they'll always look at those linearly, meaning supply goes up, supply goes down. How has those factors led to various mortality? Well, fentanyl has gone up. Prescription opioids has gone down. So then people ascribe cause and effect to simple linear relationships when it's anything but. And as somebody who's well versed in the financial world, you know that sometimes things are not cause and effect, there are degrees of correlation, and things vary non-linearly. And I think that it's time we look at the overdose crisis, which is how I'm going to characterize it. How we look at the overdose crisis as a complex phenomenon in which there are degrees of correlation that may not relate linearly, but may relate in complex patterns. So you can't say, oh, we're making inroads in the overdose crisis because prescription opioids have gone down, and on the other hand say, well, we don't know why fentanyl overdoses are going up. There's always that substitutional pattern, that substitution cost in economic terms that really exemplifies behavior in general, not just patient behavior, but behavior in general. People look at the margins, and that's always how people react. Lawmakers look at the trends and look at the change in the trends and assign retroactively cause and effect. That's again looking at the margins and not looking at the entire picture. A patient with a substance use dependency who's making a decision between prescription opioids, fentanyl, or heroin is always going to choose whatever produces the most significant high at the lowest risk of obtaining that high. So they always make that opportunity cost. So now you have these complex players. You have the state AG offices. You have the lawmakers and the policymakers. Everybody looking through their own simplified lens of linear cause and effect, trying to play on the margins as what they see it. And in the end, nobody really has a full picture of the overdose crisis.
Yeah.
I think what we need to do now is to just take a step back and really start to look at the experience of heroin, fentanyl, prescription opioids as it pertains to the patients first and foremost, because those are the individuals who are most affected and truly the most important people in all of this, and then create laws that reflect the true accuracy of clinical behavior and use the law to regulate clinical behavior, not dictate clinical behavior. And I think that requires a lot of us to come together, get rid of these preconceived notions, stop looking at this overdose crisis as cause and effect and linear relationships, and really start to hear what other people have to say.
Can you
And then you'll start to piece together the puzzle.
can you say that one more time? You said create laws that track the true accuracy of the patient behavior.
That reflect the true accuracy of clinical behavior. If a patient with diabetes cheats on their diet and starts to eat cake because it's their daughter's graduation, you're not going to take away the diabetic medications and say, you don't deserve those diabetic medications, you were not complying with your diet. Instead, you would work within the parameters of that patient's life, help them to understand the decisions they're making day to day, those margin-based decisions day to day that impact their diet. Same thing with chronic pain. Same thing with substance use dependency. Recognize the journey, the life of a patient day by day, and what dictates those decisions. Because that is essentially medicine. A series of clinical decisions made by a patient day by day, viewed over time, is clinical care. You want to optimize those decisions because in optimizing those decisions, you optimize patient behavior. That is fundamental to clinical medicine, and law should recognize that and work within those confines of optimizing the clinical relationship between the provider and the patient instead of dictating how that relationship should work.
Right. I think you touched on an important point as far as drug seekers. They're going to look for you know the the biggest high at the lowest risk. I think you saw the lawmakers with the opiate lawsuits looking at the biggest bang for the lowest risk. There's no risk. Once Trump threw in the gauntlet and said, to think that you could sue drug manufacturers for selling legal drugs, 10 years ago that would have been kind of like nonsensical. How can you sue somebody for selling legal
And
drugs?
you know what's very interesting about that? Uh, I wanted to, and I apologize for
No
cutting you
problem.
off, but I think this is a very important point. Drug supply, drug quantity is not dictated by the market. It's regulated annually by the FDA, who then seeks input from the CDC, from Congress, from the DEA. So there are caps on how much of each drug can be manufactured. That's diabetic drugs, hypertensive drugs. So the notion that market forces were responsible for the increase or decrease in prescription opioids while not taking into account the regulatory forces that are creating these supply caps is at best an ignorant understanding of healthcare economics, and at worst a disingenuous application of how supply and demand really worked when it comes to prescription opioids.
Fair, but my point that's a good point. But the point I'm trying to make is that for the state AGs, once Trump said we're going to bring these opiate manufacturers to task, there's something wrong with this picture. Now, whether you cutting supply is going to fix it, but there's something wrong with this picture. Why in the world are drug overdose deaths surpassing car accidents? You know what I'm saying? So when he threw down the gauntlet, now there's no risk to the state AGs. There's no political risk. You know what I'm saying? Because
Yeah.
they can basically piggyback off what he's doing. So you have this strong man in office who's making these. This is how I feel, and this is what we're gonna do. come hell or high water. I'm gonna be a billionaire if I get put out of office or not. So I don't need to be a politician. And so now you got these politicians who can go after these drug manufacturers for billions of dollars with no political risk.
Yeah,
And they're going up for a
exactly.
public nuisance claim, and they've been told over 100 times you can't get a public nuisance claim against drug manufacturers. They can't decide. They can't. They have no authority over how somebody uses their drug after they produce it. And
Yeah.
so I think it was also sort of like I think they was also trying. Excuse me. I think they were also trying to get this public nuisance claim, so certain state AGs, to then try to make the same argument for gun manufacturers. I think they're going to try to use that as a way to also regulate the supply of guns to get a public nuisance claim against gun manufacturers. So it was a much bigger picture.
When does it stop, though? When does it stop? Right. So what's very interesting is that the public narrative can influence the interpretation of laws that then dictate how those laws are applied and the subsequent implementation of those laws. That is a very slippery slope to fall on because you're losing the legal compass by which laws should be interpreted and applied. There's no fundamental fairness at that point. It's really blowing in the political whims of whatever is the most strong narrative.
Right. I think I'm not a politician, so I don't understand their logic. I think they have a special logic, but I think they were definitely using this as an opportunity. Once we get this public nuisance claim against these
Yeah.
drug manufacturers and get the public mad at the drug manufacturers, now we would get this win in court. We're gonna go for the gun manufacturers. And I think the judges saw that. I think the judges saw that. But so when you talk about what is the end in terms of the actual overdose deaths, where does it end? I mean, because we still know that fentanyl is driving these drug overdose deaths, and they've sued drug manufacturers to tune billions of dollars, tens of billions of dollars. They cut prescriptions. They basically handcuff doctors in a lot of ways about what they can prescribe. Maybe the best medicine for, post operation medicine for patients to regulate pain. Maybe it is hydrocodone or OxyContin, but some doctors are handcuffed, but they're not allowed to prescribe it. So where does it end? I mean, what we're doing now is not working, but where does it end? I mean, these numbers we can look at it again in 2022. There's still going to be a double-digit rise in drug overdose deaths.
So the physicist Max Planck once said, "Science advances one funeral at a time," implying that when the old guard changes and the new prevailing thought becomes the predominant narrative, things start to change. And so what I think you're starting to realize is that harm reduction or clinically approved and validated methods of treating patients with substance use dependency, patients with chronic pain, leads to better public health outcomes than legal draconian policies absent any sort of medical basis. And it sounds very obvious when I phrase it that way, but the notion that you can moralize pain or addiction as good or bad and create legal policies around that is really what has led to the exacerbation of the overdose crisis. I think it'll start to change once a slew of clinical literature seeps into the mainstream and percolates into the halls of Congress, the halls of state legislators, where now they realize that harm reduction is actually the appropriate way to deal with overdose crises, not just with opioids, not just with heroin, but with methamphetamine, with cocaine. All drugs of abuse, all illicit substances, prescription medications, alcohol, which is still one of the biggest drivers of overdose and substance abuse, all of those entail a form of behavior in which patients are behaving either in a dependent manner or an outright addicted manner, depending on the level of self-harm or harm to society. All of those cases require a harm reduction approach to ensure the patient is safe and that the patient cannot inflict harm onto society. When you abruptly discontinue whatever is the traditional pattern of behavior for that person is going to behave in a reactive manner. And that's what we saw in Tulsa. That's what we're seeing with the scores of patients who are denied medications to prescription opioids that they've had for years, now leading to patient suicides.
Mm-hmm.
Abrupt discontinuation in medications or abrupt shifts in behavior always produce a counterintuitive reaction. Only with harm reduction can you create patterns of behavior in which you can predict a reduction in harm to the patient and a reduction in harm for that patient to society.
Right. And so in my book, I wrote a book called Shock Exchange, how inner city kids from Brooklyn predicted the Great Recession and the pain I hid. I wrote about mass incarceration and the drug trade, how they're locking up drug dealers. That just dealing with supply, cutting supply is not really going to matter. That's how you deal with, from an economic standpoint. It's not how you deal with the drug trade. For instance, if that's 10 drug dealers, right, and you lock up 5 of them, the 5 that's still remaining can still service the demand for the that's left by the other drug dealers. They can still service the other 5 drug dealers' customers. So you have to deal with it on the demand side. You have to sort of find a way through treatment. You have to deal with it on the demand side, and that's not what's being addressed. And we talked about on the show a lot because even in the music, listen to the young rappers that are singing about Percocet, singing about Xanax. This is rapper named Future was singing a song called He kept saying Percocet, Molly Percocet, and I'm singing along. I had no idea what he was singing about. I had no idea he was singing about taking prescription drugs. Like, why would you take Percocet for? Who does that? You know what I'm saying? This is what's in the music. This is what young people are talking about. They want to get high for some reason. Why is that? And the kids are telling you what's going on in society. You have a bunch of rappers ODing on Xanax laced with fentanyl, or somebody ODing on cocaine laced with fentanyl. That type of stuff. So the kids are telling you what's going on in society. And I wrote about in the book that you can't basically if you just lock up a bunch of drug dealers, it's gonna be the drug dealers left can go take up that provide that demand service those other customers. You have to address it on the demand side. I think that's what we're seeing, and I think Dr. Kolodny said in the previous show we talked about there's a lack of hope. Why is that? I think he's getting off this narrative that prescription opiates. If we had diagnosed it, had people like you who could diagnose this issue 6-7 years ago, instead of talking about prescription opiates, we've been a lot closer to a solution. But from an economic standpoint, I think the economy is poor. I think since the financial crisis, printing money and giving to the Obama administration, printing money and giving to his donors, somebody he wanted to work for when he left office, somebody he wanted to sleep with. It's not economics. And so now you're going to see, now we're going to see another recession. And the people who's printing his money to are going to hoard the cash. And I think it's only going to get worse. I think that's what, people wanting to get high. They're telling us something. The people aren't happy. And there's a lot less opportunity for young people today than there was when I was coming up. And it's more, still dealing with institutions and worrying about institutions and hoping it trickles down. But what's trickling down is inflation, higher costs for college. You can't afford to go to college anymore. So for someone like me who had a puncher's chance, and when I was coming up, I could go to college. It gave me a puncher's chance. You don't have a puncher's chance anymore to work your way into middle class status. What's trickling down is, again, higher gas prices, higher costs for college. You can't afford a house anymore. Institutions are buying up all the houses and raising the price to the point where you can't afford one. Why wouldn't people get high? Why wouldn't we have a drug crisis? You know what I'm saying? Why would anybody believe we don't have a drug crisis in this country? And in my opinion, the U.S. is a crumbling empire. And you can talk about American exceptionalism, but that's just happy talk. There's nothing. What we have is rising inequality, mass incarceration, and rising costs to the point where people can't afford. Almost can't afford to live, and then you don't have the opportunity to get yourself out of your economic situation. So why wouldn't we have a drug problem? That would be my question. And I think that's what the politicians, it's like they continue to deflect. Oh, it's a gun. We got to do something about guns. Oh, we got to do something about drugs. No, we had to do something about, politicians setting policies to help their donors and not addressing the whole country, in my opinion, from an economic standpoint. So why wouldn't we not have a drug problem? That would be my question.
Yeah, no, that's a good observation, because you're talking about particular moral failings throughout society that are leaving the disenfranchised with no sense of an outlet, no sense of an upward mobility, which, as you alluded to, is the definition of the American dream, the American exceptionalism, that no matter how hard you work, so on and so forth, you will succeed. A lot of people are not seeing that anymore. And I think you hit it on the head when you talked about these drug crises of different substances are essentially a failure of the younger generation to see a positive outlook or a sense of growth in their own trajectory. And so it is by nature a demand-sided issue. And that's where principles of harm reduction come in. And as you alluded to, understanding the sociological thoughts of the younger generation and that sense of loss that they're experiencing all point towards one conclusion, that if you address the demand, the mental crises that are leading to the drug crises, provide economic opportunity, you won't have to resort to punitive means to essentially take this whack-a-mole approach to whatever you want to blame, whatever your donors are telling you to focus on. Instead, you would look at it from a societal standpoint. You would look at it outside of that lens of cause and effect. And I think we are seeing something together. Your perspective from the financial and economic standpoint, my perspective from the medical standpoint. And it's not surprising that we're looking at this from the same lens, because we both understand the issues that are leading to patient behavior. It's a demand side construct, because supply and demand when it comes to drug abuse is not linear. It's not an X where you have supply and demand. It's very much curved based off of the mental stress, the mental anguish that people are going through, the sense of loss, the demoralization that then creates different behavioral choices. That's not linear. That's a complex societal problem.
Yeah, but I think we have a, I think our interests outlined. As a doctor, you want to be able to treat patients with the most effective treatment you possibly can. And we talked about this in the previous show about, this from a layman's standpoint. I'm hearing about, like, Endo they took a pawn off the market voluntarily because the state AGs was complaining it wasn't crush proof enough. Who's crushing drugs? Who's crushing Opana? You know what I mean? And the people I've spoken to said that's a utensil you get to have. I asked some guy, do you just crush it with like a hammer or like a nutcracker or something? He said, no, it's something you buy at the store. Apparently, you have to have this utensil on you at all times in case you're walking down the street. You have to see a bag of Apana on the sidewalk. You don't want to miss your opportunity. You know what I'm saying? But they're crushing. So Endo got accused of not making Apana crush proof enough. So now that's in a way, from my understanding, there's a lot of opiates work for pain, but some have different side effects, affect people differently. Side effects have, people have different side effects versus OxyContin versus Opana or Lidoderm or Vicodin. Maybe Opana worked best for patients, for pain patients, certain pain patients. Now they can't get access to Opana, which worked best for them in terms of treating pain with the limited side effects. They can't get access to Opana now. And we have our interest online. As a doctor, you want to give your patient the best treatment possible post-surgery. As a potential patient, we're all going to be in pain someday. Believe me.
Yeah.
I mean, I had a back injury a couple years ago where I had like a pinched nerve. It didn't require opiates, but the pain was radiating around my back. You know what I'm saying? At some point, we're all going to be in pain. Period. You want to have the best treatment for your pain. And apparently, taking these drugs off the market is hurting pain patients, and it's causing me sort of agita because we're all going to be in pain one day. And those are the facts.
I'll give you a great analogy to look at. So let's take COVID-19 vaccines. Moderna has proven in certain situations to increase the immune response among patients relative to Pfizer. So if you were to just simplify that argument, even though that's not entirely accurate, you could say, hey, well, Moderna may be a little bit better than Pfizer. That's not entirely accurate, but it's just true enough with the limited data and limited sample size of studies where you can say, okay, sure, Moderna's better than Pfizer. Let's take away Pfizer. Let's take away Johnson & Johnson. And a new vaccine that just came out a few days ago and recently got emergency use authorization, the Novavax vaccine, let's take that out as well. Let's just only focus on Moderna because that's the best one and everything else is dangerous. Now all of a sudden you have supply issues. Now all of a sudden you're beholden to one treatment modality, and now all of a sudden you're taking all the patients who receive COVID-19 vaccines and lumping them in one response profile, whereas some patients may benefit from Pfizer, they may benefit from the access of it, they may not need a heightened immune response, their immune system is capable enough. So you have all these types of unique idiosyncrasies per patient that benefits by having a multitude of options available. Same thing with chronic pain. Same thing with high blood pressure. You treat different patients with blood pressure, elevated blood pressure, with different blood pressure medications based on their underlying medical conditions. Same thing with chronic pain. If they have kidney failure, you probably want to avoid acetaminophen or certain non-steroidal anti-inflammatory drugs. You want to look at the patient and then determine the best option for treatment based on the medical needs and underlying conditions of that patient. You don't want to simply say, I'm taking this away because I believe a potential risk of abuse is greater than the actual clinical need that you're presenting with. That is a fallacy in thinking in which the potential risk of diversion is seen to be greater than the actual risk of untreated pain. And that's why we have a lot of the problems that we have, because they're not assessing the risk of potential risk and risk of actual risk in the proper balance.
And that's what's driving people. That's what's getting people dander up, because you get a sense that that the politicians are picking the winners. And when you describe it that way, you basically, the politicians are picking, wealthy individuals whose kids have maybe died of a drug overdose, who have access to. You pick up the phone, call the state AG. You taking their interests over the interest of patients, and over the interest of doctors.
Whoever creates the most effective narrative,
right? And over the interest of doctors who want to treat their patients, and pain patients can't get access to the proper treatment post-op. And from the economics, I studied economics in college. You got these politicians saying, we're going to print money and give it to the investor class. We're going to print money and give it to Goldman Sachs and Morgan Stanley. There's no economists anywhere. Black, white, digital, lie will tell you print money, give it to your donors, somebody you want to work for when you leave office, or somebody you want to sleep with. And hiding behind economics. This is serious stuff. And you make it out to be some type of gimmick. Using words like economics and economy with this nonsense. You're picking the winners. And that's what pain patients feel. That's when you hear, when you talk to pain patients, you hear them feel like the government's picking the winners. And they're not the winners. It's somebody who's, who want to create this narrative. And there's a lot of, there's tens of billions of dollars involved when you're suing opium manufacturers to stick with this narrative. And it's going to the coffers of state AGs.
The narrative has led to a gross oversimplification in which people are manipulating the emotions of those who have lost loved ones. And it's actually pretty sadistic if you think about it.
A mother's pain.
You are essentially taking a mother's pain and saying, it was that drug manufacturer's fault that your son or daughter overdosed off of heroin. Because if they didn't get those prescription opioids, then they would not have turned to heroin.
Right.
That may or may not have been true, but that's true enough, so we're just going to keep that narrative.
Right.
Your pain is due to that opioid manufacturer, and you're exploiting the sense of loss. I mean, one of the most visceral senses of loss, a parent losing a child, a husband losing a wife losing a husband. This is visceral, fundamental pain. People can be easily manipulated when that pain is channeled towards a scapegoat.
Right.
And that's what you see with these people who are perpetuating this simplified narrative.
Right, but they kept it. The thing about it is they kept the narrative up. Even when, to a man, they kept on the same narrative. Like even when the prescription opiates were cut dramatically. And I'm trying to figure out, why would drug overdose deaths go up? You know what I'm saying? And they said, well, now the pain patients are turning to, after they became addicted from opiates, are turning to opiates on the black market, or turning to, other drugs, turning to heroin. So they kept the narrative up. But so I'm gonna try to share my screen. We're gonna talk about. Unless you have any more points on this issue. Okay, so we're gonna turn to the mass shooting in Tulsa, Oklahoma, where a pain patient shot a doctor and a couple of doctors and another patient in Tulsa, and just sort of have you speak to that as well. So I'm going to try to share my screen right quick.
Sure. Let me know when you want me to begin.
Okay, I'm just going to play the video right quick. Right.
Michael Lewis went for a back surgery. The performing physician was Dr. Preston Phillips. Mr. Lewis was released on 5/24, May the 24th. After release, Lewis called several times over several days, complaining of pain and wanted additional treatment. On May 31st, Dr. Phillips saw Mr. Lewis again for additional treatment. Yesterday, June the 1st, Lewis called Dr. Phillips' office again, complaining of back pain and wanting additional assistance. Now, we know through the help of our ATF and their gun tracing that at 2 p.m. on June the 1st, Mr. Lewis purchased a semi-automatic rifle from a local gun store. That semi-automatic rifle was an AR-15 style rifle. We know that Mr. Lewis purchased a semi-automatic handgun, a .40 caliber Smith & Wesson pistol, on May the 29th from a local pawn shop. Thus far, we have recovered 30 .223 casings from the crime scene. We have also recovered 7 .40 caliber casings from the crime scene. We have also found a letter on the suspect which made it clear that he came in with the intent to kill Dr. Phillips and anyone who got in his way. He blamed Dr. Phillips for the ongoing pain following the surgery.
Sad.
Okay. So that's I just wanted for our viewers so they make sure they have the right information. But when it first came out, I think, wow, another mass shooting, because you had Buffalo and you had Texas. Then you had President Joe Biden make a press release about guns, right? And you had a bunch of journalists talking about guns. You do something about guns. There was like another gun narrative. And just so you know, I remember when I was in college, like the second semester of my last semester of my senior year, it's like the late 80s. That there was a bunch of black women out in South Central LA complaining about guns. It's back in the late 80s, and nobody cared because there was a bunch of gangs who were out there fighting. And in the 70s, they would fight with sticks and stones. By the late 80s, they were using semi-automatic weapons. They were complaining about guns, and the narrative was that guns don't kill people; people kill people. People thought it was funny. Now, decades later, now we're still in the same issue. But a bunch of journalists after this incident in Tulsa were talking about guns. We need to do something about guns. And then it came out that this guy was a pain patient. And the way he described, he said, he described it as insufferable pain. And after that came out that this guy was a pain patient, and he talked to a doctor, all of a sudden the news reports went away. The news reports died down. So I just want to get your take on the incident in Tulsa.
My first takeaway is that it's an incredibly sad situation. The physicians involved, one was an orthopedic surgeon, the other was an internist, highly accomplished in their fields, highly respected. In the medical community, those two physicians did a lot more than most physicians would do in helping to cultivate young residents and young medical students. So in that light, the medical community lost two champions of medical education and of healthcare in general. That all being said, I think the situation is best understood by going through a sequence of decisions that culminated in that tragedy. You have a patient who underwent a spinal surgery, one of the most invasive and sensitive from a pain standpoint surgery that a person could go through. They were being treated with post-operative pain medications. We don't know the decisions that led the surgeon who lost his life to prescribe the quantity of medications that he did. We don't know what led the patient to complain of the pain that he was experiencing and then calling his physician, the surgeon, over and over. There was clearly a disconnect. Now, you can extrapolate why that disconnect occurred. We can talk about the type of stigma associated with patients with pain that has come about due to the overdose crisis. We can discuss lack of patient-to-physician communication that's also endemic in the healthcare system. And we can discuss access to guns. It's really not a mutually exclusive construct. This is a tragedy that unfolded due to a series of decisions. A patient received a surgery, experienced postoperative pain, did not receive adequate pain relief, chose to then obtain violent means of addressing that pain, because that's really what that tragedy was. It was a patient who could not obtain relief for a clinical condition that then made the active decision that if I cannot receive proper clinical care, I will react in a violent means. And that's what we talk about with unintended consequences when it comes to untreated pain. We cannot predict how the response will unfold, but what we do know from this incident is that response entailed gun violence, because when you look at the sequence of decisions that took place in the mind of that patient, he thought, if I cannot receive adequate pain treatment, I will then obtain a gun. It's not unique in that circumstance, in that there are many patients who commit suicide when they have untreated pain.
Right.
And I'm not creating an equivalency between a murder and a suicide. What I am instead emphasizing is that there is a conscious decision made in the minds of patients with untreated pain to then use guns or use means of violence as a way to address or react to untreated pain. And I think we have to be very mindful of looking at this abject tragedy from the perspective of decisions made over time and what led to that individualized decision being made. You can talk about guns and access to guns as an issue. You can also talk about untreated pain as an issue. But in order to understand the full context of why this tragedy unfolded, you have to look at the role that untreated pain has with access to guns and the minds of those who are making those decisions of equating those two, whether that results in a suicide or a murder. There is a clear connection in the minds of those who are experiencing untreated pain to make decisions that relate one to the other. And that needs to be investigated, and that needs to be studied clinically.
Right. I mean, from a layman's perspective, my fear is that if someone has pain and they aren't, for whatever reason, and they aren't getting maybe it's misdiagnosed, they can't get access to proper treatment because of some regulations, whatever. Someone's in pain, they can't get access to the proper post-op treatment. They're gonna hurt somebody. That's just kind of like from a layman's perspective. That's my biggest fear. And the other thing is that a lot of the story kind of died down when it wasn't just gun related. You know, that's the other thing I noticed in the media. Then when it was just, not to say just, but when it came out that you had a pain patient that had, communicated back and forth to his doctor, that narrative wasn't really as explored as much as the gun narrative. And when it came out he was a pain patient, again, the story seemed to have died down. And it wasn't explained the way you explained it. This is like the most invasive type of surgery. This is really complicated stuff. Like I said, I had a back injury. I got hit in the back, and the pain was radiating. I couldn't even describe. First it was over here, then it was over there, but the pain was radiating. I didn't need opiates, but I was in pain. I was definitely discomfort for several months. So it's a sad situation, and You still don't know exactly what he was being prescribed, or what if the doctor was limited in prescribing certain drugs. We just don't know, and it's we need to. I think the information should be shared with the public as much as a gun related incident solely.
I think we have to focus on that uncertainty and look at it from that comprehensive standpoint. Otherwise, we're going to react reflexively. We're going to say, well, of course, it's the untreated pain that caused it,
Right.
or of course, it's the access to drugs or to guns, rather. I think if we go along that rabbit hole of thinking, we're going to get into the situation where we're blaming the number of doors in a school, like what they're doing with the Uvalde situation, and it becomes almost kind of play of absurdity. I think instead we have to really focus on the minds of those with untreated pain, untreated legitimate pain, and how they make decisions and how they perceive the calculus of decision making, and optimize that so that you don't have patients feeling as if they have to resort to violent means, either self-inflicted violence or violence upon others, in order to receive what they believe to be medically appropriate care. And that's the real crux of the matter here. And the real tragedy post death for all these individuals is that we're not looking at that situation in that light. We would want to just jump to whatever is the most convenient narrative, and if the facts don't fit that convenient narrative, like you alluded to, the story doesn't go.
That's why I was
It's sad state of affairs.
that's why I was really pushing for you to be on the show, because I didn't want to say anything about the situation unless I had a doctor who could dissect this. I didn't want to make a knee jerk reaction because I just don't know, and the public just doesn't know because we don't have the right information. We don't have enough information. And hopefully, we'll get some information over time. But I didn't want to write an article or do a show on it without knowing myself.
Yeah.
I want to make sure I get the proper information
Well, I
to
think
people.
what we need to do is really examine the relationship between a physician and a patient, any physician, any patient, actually, for that matter, any healthcare provider and a patient, and study how the exchange of information takes place over the brief duration of communication that defines a patient visit, and how much law and policy influence that conversation. If you and I are having a conversation where I'm defaulting to trusting you, that conversation is going to be much more different than if I'm defaulting to not trusting you and instead fearful of some sort of legal ramification in making a clinical decision. That is, without a doubt, a fundamental truth that nobody can really dispute. The issue really at hand is how much of an influence is appropriate and how much then becomes clinically harmful. And clearly we have not found that line,
Right.
because we're resulting in so much patient harm that we have to find a balance between what is appropriate oversight of the patient-physician relationship and at what point you're tearing the fabric and forcing physicians to either choose a clinical decision or legal self-protection. And I think this tragedy really highlights just how nuanced and complex of a decision that really is. And I think the best way we can honor the lives of everybody involved, that patient, the physicians, everybody, because, that patient did not choose to be in pain. That patient underwent a surgery, and that patient was in pain post-operatively. So I think we have to at least understand what's going on in that mind of that patient. This was not an unprovoked, premeditated murder. This is clearly a reaction to something that was taking place and a sense of disenfranchisement that took place by not receiving what the patient believed to be medically appropriate care.
Right, and
We have to really understand that.
we're all going to be, and I think the public it's an issue of extreme a public interest because we're all going to be in pain one day, and we're all going to want the proper care. From economics, from a high level, I think as far as the drug overdose deaths, what have you, I think the situation is not going to get better. I think the economy, after all this money printing, I always said that when the public finds out after all this money printing that we're still going to have another recession, I wonder what the public reaction is going to be. I think it's going to be more social unrest. And in my opinion, at least it's done with the Obama administration, all he did was make sure there's going to be another recession. You don't print money and give it to your donors. That's not how you help the economy. But all he did was make sure his donors, somebody he wanted to work for, he left the office, or somebody he wanted to sleep with, they would not bear the brunt of the next recession. And so a recession technically is 2 consecutive quarters of declines in GDP. Q1 GDP declined by 1.5%. And Q2 is at the end of June. Things are going to decline again. And so, and they usually put the data out maybe about GDP maybe 3 weeks after the quarter. So around July 28th, towards the end of July, the government's going to announce that GDP declined again, and we're officially in a recession. So I wonder what the populace is going to do then. You know what I'm saying? I don't know why anybody would think we're not going to. We shouldn't have a drug problem with the Dow at over 30,000, asset prices going to the roof, which is helping people who own the assets. And for the 99%, 98% who don't own the assets, what are they going to do with costs going up as well? Gasoline prices going up, rent going up, cost for housing, cost for college going up. So I think it's going to get worse. The other thing is you talked about harm reduction. There's been talk of drug injection sites. New York is one of the first. It's one of the first ones. I think they have one in California as well. Have we gone to legalizing drugs first of all, and then I know we're trying. It's almost like trial and error. Let's cut prescription and then have drug injection sites. Have we legalized drugs, and at what point do these numbers, if at all, do they help these overdose deaths, if at all?
Well, I think we're headed towards a destigmatization of drug use. I'm not sure if that translates to a legalization outright, but I think what we're looking at is a destigmatization and look at patients with substance use dependency as opposed to criminals with addictions.
Mm-hmm.
And I think that conceptual shift is a big move forward in understanding that overdose crises is a demand-sided issue and that we need to focus on identifying ways that the patient can reduce the harm to self and reduce the harm to others, and having safe sites, having these types of facilities in a public health forum where patients do not feel stigmatized would help alleviate a lot of those reactive behaviors that come from the stigmas of experiencing certain conditions.
Okay. The other thing you mentioned earlier that you hope, from a public policy standpoint, you hope doctors and policymakers and lawmakers can come together to figure out the best path forward. How do we do that?
Well, I think what we're going to see is an age of populism in healthcare, where people are going to take a much more grassroots approach to all healthcare issues, drug prices, access to care, insurance reimbursements, deductibles. We're going to start to see some changes that we thought would never really transpire. We never really imagined that the insurance industry would lose its grip on healthcare. It's starting to. Medicare Advantage plans have proven not to be effective. This whole construct of third-party payers is not as efficient as what we would like to believe. A lot of the fundamental institutions in healthcare are losing their grip on the traditionalism of healthcare. And in that vein, we will see a lot more populist type sentiment where patients will come up and say, I'm not paying that monthly premium. I don't think I should have to pay X, Y, and Z for that. I'm not going to accept those previous preconceived notions in healthcare. And physicians will respond in turn. And you'll start to see a lot of populist sentiment in which people will be questioning established status quo conditions in healthcare infrastructure. That's the concept of a hospital, concept of outpatient care. And a lot of that will translate into healthcare innovation. A lot of that will translate into public protest. But what you will see is a fundamental questioning of established healthcare institutions that will manifest in a myriad of ways. It truly is an age of populism in healthcare, whether we realize it or not. And it behooves us to be more actively involved in all aspects of healthcare so that we can be in a position to help influence healthcare for the better for people like us, as opposed to having changes imposed upon us.
Mm-hmm. Okay, so, we have a couple of people in the audience. Do you have any questions for Dr. Joshi? Ask now. We're running up on an hour, so we want to make sure anybody has any questions for you to get the questions out. Any questions in the chat room? Okay. So what did we, Dr. Joshi? If you have any questions, you can always ask. What did we not cover that you wanted to cover?
The main takeaway that I would like to express for the listeners is to avoid jumping to conclusions in healthcare and really embrace the complex nature of healthcare, that there are a lot of things we don't know and we will never know in healthcare. And that's okay. We have to be okay with that. We have to be okay with never knowing what truly led cause and effect to that patient murdering that surgeon. And we should avoid jumping to conclusions, because that's a disservice to the patient and to the physician and all those who lost their lives. Let's study the decisions in healthcare, embrace this uncertainty, this sense of not knowing. And it may seem counterintuitive. It may seem that we're just kind of throwing our hands up. But I promise you, if you start to think about healthcare in those lines, you'll start to understand fundamental patterns that appear all across healthcare, whether it's the overdose crises, gun control, abortion. There's common themes threading throughout healthcare that become apparent when you start to understand that, hey, this thing is a lot more complicated and a lot more uncertain than I ever thought it could be. And once you embrace that mindset, that way of thinking, you start to realize where these trends are coming from.
I listened to, thank you for that. I listened to I think it was State AG out of Nevada. I think I listened to him talk about the amount of opiate money he got, and then we're changing the narrative. I think we're getting people to focus more on, it's more of fentanyl and overdose crisis, less on prescription opiates. But I think you mentioned something about fentanyl dealers. They're addressing fentanyl dealers in certain parts of Nevada that's outside of the cities or what have you. I mean, is that an improvement above? Then we're focused on fentanyl, but is that an improvement on focusing on fentanyl dealers? Is that an improvement on focusing on opiate prescriptions? Because you're still not addressing the demand side. You know what I'm saying?
It's a whack-a-mole approach to legalizing healthcare problems, right? When you apply legal punitive measures to healthcare, you're essentially looking to punish whatever seems to be the problem of the day. So yesterday it was physicians. Today it's fentanyl dealers. I think we need to step away from this punitive approach to substance abuse and then look at more restorative ways of addressing what's going on in society. If it's not fentanyl, then it's going to be the next substance that's even cheaper, that's even more potent. And so you're going to keep progressing. It's almost like Zeno's paradox, where you think you're addressing an issue, but you're just cutting in half, cutting in half, cutting in half. And you never actually accomplish the goal. You never reach the finish line because you're never looking at it from a fundamental standpoint. You're not looking at it, as you had mentioned, drug abuse, substance abuse, as a demand-side construct that comes from existential issues that we are facing in society that then manifest as substance use dependency, as worsening untreated chronic pain, as the stigmatization of certain clinical conditions and of certain behaviors. Let's get away from that. Let's destigmatize medicine and let medicine be medicine.
Okay, well said. So that's Trump and the GE on drug overdose deaths in Tulsa mass shooting. Thank you for tuning in. Thank you so much to Dr. J. Joshi for helping us parse through these complicated issues. And again, thank you for tuning in. Stay tuned. If you have any questions for Dr. Joshi later on, let us know. We'll reach out to him and get his responses. But stuff is too important to just let laymen sort of or the media just gloss over it. We need professionals who know this stuff and can help explain this to the public in a way that's understandable. Again, thank you for Dr. J. Joshi for joining us. And that's Trump and the G, and we're out, and we'll see you in a couple weeks. Thank you so much.